Well, good morning, everyone. I see my glasses are a little bit dark because I've been outside. I want to welcome you to Odyssey's Lunch and Learn. I'm Michael Connolly, the owner and director of Odyssey, and today we have with us Donna Goldstrom. And Donna, I've known Donna for over 20 years. Donna took most of her CAC training with me and other trainers at Odyssey, and went on to get her certification as a trainer and started training at Odyssey about 15 or 16 years ago. Right, Donna? I think that's true.
About that, yeah.
Yeah, it's amazing. And Donna specializes at Odyssey in doing online classes, and she primarily does the principles of addiction and what used to be client record management, which is now called case conceptualization. Donna has really focused her career, working in addiction, of course, but really focusing on opiate addiction and medically assisted treatment, or as we all know, MAT. Currently, she's the director of the Front Range Treatment Services for opiate addicted people all over the state of Colorado. And so what she wants to talk to us today about and just kind of share some of her experiences. And she's really on the cutting edge of, I think, the worst crisis in the addiction world since I've been in it, which is over 40 years. And that's the opiate overdose crisis. So she wants to talk a little bit about what's going on with opioid treatment, what's happening, what's new, what's working, what isn't, and where are we going from here? You know, what do we see in the future? Because this is really an unbelievably devastating and tragic epidemic. And it's just kind of been overshadowed by everything else. I mean, all the politics and COVID and everything, but man, it has been unbelievable. So I'd like to introduce Donna. Donna, welcome, and you're on.
Awesome. Thank you so much, Michael. Yeah.
I did want to mention we're going to mute everybody so that nobody's going to interrupt you, okay?
Great. And then if anyone has any questions, we do that at the end. Is that?
Yes. We have a little chat thing too, so you can just type in your question.
Perfect. Perfect.
Great.
Well, thank you so much for doing this. This is just such a great idea. I have been working with Odyssey for so long, and I used to drive down to Denver. I live in Fort Collins, and I used to drive down to Denver to do classes in person for 3 or 4 days a week. And this whole online business is just so fantastic. Don't have to do that, but the online thing really does remove that sort of in-person personal touch. So I'm glad you're doing these intros and these lunch and learns and video biographies, because any way that we can add that sort of in-person touch is great, in my opinion. But so thank you. I'm Donna Goldstrom. I have my LAC and my LPC, licensed professional counselor and licensed addictions counselor. I originally went to school in Ohio and then moved out here right after my master's program to start my work in 1997. Moved to the Boulder area and then migrated up here to Fort Collins. And I started, I've worked at Centennial Peaks down in Louisville. I started most of my career at, if anyone remembers, Arapahoe House down at the adolescent residential unit in Thornton, and then up here working in outpatient addiction treatment. Most recently, I worked for about 15 years at the Family Medicine Center, which is a residency training program for family practice physicians. And my job there was to integrate addiction treatment and integrate substance use services into the family medicine training program, which was an amazing experience in really stigma busting for our family docs and training them on how to treat addiction like any other disease, like hypertension or diabetes, not like it's different. So then while at the Family Medicine Center, I did start a medication for addiction treatment program there, which again was the opportunity for a lot of stigma busting. At first, they were very closed to it. And then over time, they realized their patient population really needed it. And from there, I moved on to Front Range Clinic about 5 years ago now, where I am the director of behavioral services for Front Range Clinic. And who we are is we've actually expanded beyond the Front Range now, but we are a medication for addiction treatment medical clinic. So we have nurse practitioners and physician assistants who are overseen by medical doctors, DOs and MDs, that prescribe all the medications that exist for the treatment of addiction, with the exception of methadone. We are not a methadone clinic. So we're a primary care clinic that treats addictions. And we started in 2014 as a tiny little clinic in Fort Collins. And the founding doctor, our CEO, Dr. Clark McCoy, realized that the behavioral piece was sorely missing. And so he invited me to come on board about 6 years ago to start a behavioral program. And we've learned a ton about how to integrate behavioral services into a medical clinic and treat people who have a substance use disorder with medication first and behavioral treatment as an adjunct. We are a harm reduction. We call ourselves low barrier, high access treatment clinic. What that means is that we do not pass judgment on people who maybe are still in active use, people who have poly-use disorders. A lot of times we find people get on a medication for addiction treatment and stop one substance and then find themselves still using another substance, and we do not discharge them. If that is the case, we try to get them the help that they need. We've recently started a couple programs that are called managed withdrawal treatment, because what we have found is, especially with the fentanyl crisis, it is difficult for people to get induced onto buprenorphine, or the trade name Suboxone is what most people are familiar with, because they're afraid of withdrawal. So instead of sending someone who doesn't really need the level of detox a hospital would give them, we can actually bring them in office and have them sit in our office for a few hours and induce them on the medicine right there, and provide them with medicines to help with withdrawal right there in the office. Again, it's not detox. If someone needs detox, they need to go to a hospital, but it's for, like we're seeing with the fentanyl, those people who really want to switch over to a buprenorphine product, but are just terrified to do so, or have tried and have failed. So another piece that Front Range Clinic has, our sort of specialty that started with our mobile unit project. There's 6 mobile units throughout the state of Colorado that serve different regions of the state, and to bring medication for addiction treatment to our rural and frontier populations. And Front Range Clinic runs 4 of them. Out of our Greeley, Colorado Springs, Pueblo, and Grand Junction brick and mortars, we then go out into the rural communities in the surrounding areas. So all the way up to, we had a pop-up, we were serving Sedgwick, which is darn near Nebraska, all the way down to Springfield, which is a stone's throw away from Texas, honestly. All the way out to Gunnison, we have clinics, and up into Craig in the Northwest. So really reaching all the different rural areas of the state. And what we've learned works there are these tiny little pop-up clinics. We call them pop-up clinics, where we establish a community partner, and we either rent or borrow their space. We really only need one room that's private and access to a bathroom. and we provide services once a week or a couple days a week for a couple hours. So we drive out to the rural community, have a clinic for a few hours, and then drive back to the brick and mortar in one of those cities. And it really has worked amazingly well for those little communities that don't have access to treatment, but don't have a big enough population to where we would need to rent an office space for 5 days a week kind of thing. So that is Front Range Clinic. That is who we are. You know, Michael said, I would love to talk with you about the opioid epidemic. Obviously, we all know now that it is an epidemic. It is here to stay. We can debate forwards and backwards about what started it. I used to think that doctors were responsible, and I've since learned after working with doctors for 20 years now that they were victim to the same story of lies that we were all told, that Vicodin and Percocet are non-addictive, and they've since learned differently. And doctors are now very much part of the solution to the problem. I just got off of a call or a training with the Opioid Consortium a minute ago, where now we're just all talking about xylazine, if you guys have heard about that one yet. Xylazine is not an opiate, but it does a lot of the same things to your system that an opiate does. It's actually a tranquilizer. It's actually a veterinary tranquilizer that people are taking, and it is not illegal yet. The FDA is very much interested in making it illegal because it's coming over from China. You can get online and you can have some xylazine shipped to yourself very legally, very quickly through the Postal Service. And so a lot of people are adding this to their opiates because it gives you a similar type of effect. But why it's so dangerous is that unlike opiates, it doesn't respond to Narcan. So if you've heard of our naloxone, our Narcan, that is the opiate blocker that people can take if they're overdosing on an opiate, and it will immediately revive you and pull you into withdrawal that save your life. If you're overdosing on an opiate, because xylazine is a tranquilizer and not an opiate, it doesn't work for that. And it's very scary. Of course, everyone knows about the fentanyl crisis. At Front Range Clinic, I will tell you that we used to only test people for fentanyl if they reported using it. That is not the case anymore. We simply test everyone, every patient at every visit for fentanyl because we're finding people are surprised to learn there's fentanyl in their urine because they didn't even know it was in their drugs. I just saw again on this training from the Opioid Consortium that, of course, you know, fentanyl seizures from law enforcement that's all they're doing. And they're working really hard, but this stuff is made in Mexico and transported over the border very, very, very easily. But we are seeing that it's not about heroin anymore. The heroin overdoses have gone down. It's all fentanyl these days, which is incredibly scary because, you know, it can be put into basically any substance that is a powder or a pill. And so even people who are trying to use something like cocaine can get fentanyl in it without even being aware of it. And such a tiny, tiny, tiny amount of fentanyl can make someone who is opiate naive overdose in that moment. So very scary stuff. I know you guys are all getting trained on medications for addiction treatment. I think that obviously this is a key component of addiction treatment, that having been in the addiction field for 30 years now, I can safely say it's finally amazing to see the chronic disease of addiction being treated as just that and being treated by the medical community. It's sad that it took the opioid crisis to make that happen, but really we should be treating addiction exactly as we treat high blood pressure or diabetes, chronic relapsing disease, not due to lifestyle, not due to personal choice, not due to personality or genetics alone, but due to all of those things and a multitude of other factors, people can become addicted to opiates. And we need to break the stigma that it's just, some bad behavior on people's part that gets them there.